Any question? Yes.
For a person that's had an echocardiogram post-MI, so maybe about 3 months down the track, and their LV function's not quite normal, so sort of 45-50%, and they're having some side effects from the beta blockers, so some erectile dysfunction or shortness of breath or cold feet. Would you now consider dropping the dose or stopping it and then perhaps re-echoing, or how will we manage those people that don't quite have normal LV function?
Yeah. I mean, I think if the side effects from the medication and there's not a clear, you regard a clear-cut indication as less than 40%, but here you've got an equivocal indication. I think it's definitely, if they have side effects, I think I'd stop it and see if the side effects get better, and look, and then increase the dose of the, if appropriate, the other medications. So I think. Well, there's two things. Obviously, there's a question of what's the benefit of the medication, and the benefit gets greater. Actually, there's a slide here, but the benefit gets greater the worse the LV dysfunction in terms of the prognosis. So you've got a pretty small benefit with ejection fraction of 45. In fact, those people weren't even in the studies. So I think probably the benefit of the beta blocker is relatively modest, and then it's causing these things that make him unhappy one day to the next. So I definitely think we should strive to get medications that suit the patient well, that are not causing those side effects. Yeah, definitely. It's harder when you've got an absolute clear-cut indication for the drug, like LV dysfunction, and also in that case, the side effects might not be the drug. So if you've got heart failure, for example, and they say, well, I've got erectile dysfunction and my feet are cold, well, is it, what's the reason for that? Is it the beta blocker or the heart failure? And most of the symptoms, and I'm tired. Well, but we've got a treatment that it's actually the most likely thing is he'll feel, the thing that's going to drive how he feels more than anything else is how well his heart's pumping. And a treatment, and I would say to him, well, this treatment we know has a favourable effect on the heart, but it takes a while for it to work. It takes, it takes a while, and we've just got to hang in there. And so let's just see. So if they had, ejection factor of 35%, I'd say to them, well, this is a really important medication, and the threshold for just stopping it would be that much higher. But if in that case there's not a strong indication, then I'd say, yeah, definitely look at stopping it. Yeah. So this is kind of so then very simplistic things. This is heart failure. So mostly maybe after myocardial injury, but the same principle applies. If you've got methamphetamine-related cardiomyopathy or a post-viral cardiomyopathy or anything that affects the left ventricular function, and then you get activation of the neurohumoral activation, so sympathetic activation of the renin-angiotensin system, and it turns out that those short-term responses, which are responses to maintain an adequate cardiac output, actually make the situation worse in the longer term. And then you get this sort of vicious circle, so that the and the medications that we know improve outcomes interrupt this, that they work on this inappropriate neurohumoral activation, so they block the sympathetic activation, block the renin-angiotensin system activation that happens, that seems to be driving this progressive risk. So it doesn't necessarily, the furosemide of course just gets rid of the excess fluid, and that's the thing that makes the person immediately feel better, because they don't have the pulmonary congestion, they don't have the ankle swelling. The other medications don't immediately make the person feel better. They don't feel necessarily, if they skip them out a day or two, they don't feel any worse. So you've got to realise that actually they're working over a period of time to have a favourable effect on the ventricles. And so when people stop the medication, they don't go back to heart failure straight away, unless they stop the furosemide, which can be different, but otherwise they slip into heart failure over a period of time, get worse over a period of time, and vice versa. The improvement of LV function that happens on the medication. That's why I'm a bit reluctant, the question before, well, my ventricle's better now, I'm on the medication, does that mean I don't need the medication anymore? I mean, my gut feeling is I'd be reluctant to stop it because I think it can go the other way. And then, so these are the key hormones, and then these are there's 3 basically groups of medication, and they all have, in absolute terms, quite big effects. And when we're talking about, we talk about big effects with stroke risk, but mostly when we talk about coronary disease and statins, we're talking about it's got a small effects, 1% mortality difference, and the coronary patients are dying at a rate of between 1% and 3% or 4% per year. Well, heart failure patients die at a rate of 15 to 25% a year, depending on what the disease is. And then you've got these, so there's these relative risk reductions of 30%, 30 or 39% in this case of beta blockers. That's a big impact on risk. So these are important, really important medications that really, that they're not the ones you just stop for no good reason. So the beta blockers are number 1, and then ACE inhibitors. So there's a whole lot of trials that show exactly the same thing. I'm showing these survival curves because that's the way kind of cardiologists think. We look at what happens over time with people on the placebo and what happens over time with the people on the ACE inhibitor, and you look at the risk reduction, and that's it's absolutely the same with they've done it with lots of different beta blockers and lots of different ACE inhibitors. And the third group of drug is the spironolactone that Bruce doesn't like, but if he does, but it does reduce your mortality if you have heart failure. So you somehow got to persuade them that it's worthwhile in that situation, despite the side effects.
Well, I find on the oldies, they don't seem to, whether just because their bodies are aching anyway, but it's just younger people have had trouble with the spironolactone.
Dose? What sort of dose?
This was actually a relatively small dose. The average dose in this study was 26 milligrams. Yeah, and there's quite big mortality advantage, and that's not just one trial. There's 3 trials that shown the same thing. Quite surprising. Yeah.
This was NYHA 3 and 4, wasn't it?
Yeah, this
so
was more severe, but they've gone back to the less severe heart failure. So it seems to be consistently. Now, the one very important point is these drugs have shown benefit when you've got reduced ejection fraction. So the ejection fraction is less than 40%. Surprisingly, they don't work when you've got heart failure when your ejection fraction is maintained. So that's what they call heart failure with preserved ejection fraction, and we don't actually, all these evidence-based treatments don't work to our surprise, really. We don't fully understand why that is. So if you've got preserved ejection fraction, then in heart failure you don't necessarily have to flog them with a beta blocker or ACE inhibitors or whatever. Then it's much more. Well, we don't know the treatment actually works. I mean, the diuretics work in terms of symptom relief, and presumably anything, which they probably work prognostically as well. But you wouldn't necessarily flog the person with beta blockers if they've got heart failure and preserved ejection fraction. So it's only if the ejection fraction is down.
Is the mortality less anyway?
It is less than a reduced ejection fraction, but it's still quite high. So if you've got a heart failure with preserved your mortality is high, but it's not as bad as the reduced ejection fraction. But there's definitely a difference in what works.
And it's about half your patients will have preserved ejection fraction, half will have reduced ejection fraction. And I think the preserved ejection fraction group is increasing, isn't it?
Yeah,
because it's often women who've had hypertension for most of their lives, so, and MIs are going down, so we'll see more. Yeah.
Certainly in the older population with heart failure, it's often heart failure with preserved ejection fraction, and that's yeah. So we'll just skip over that. So this is well, what's this ECG show? It does say there. So this is left bundle branch block, and I must say, until about 10 years ago, we thought, left bundle branch block. It's just an electrical alteration of the conduction of the heart. That means that we can't interpret the ECG because it totally changes the way the electrical activation of the left ventricle. So you can't see all the things we normally see, including acute myocardial infarction. It actually turns out that it's actually much less efficient way of activating the heart, because what happens is that the left ventricle is activated so the impulse goes down the right bundle on the right side of the septum, and then slowly activates across the ventricle from right to left. And so this means that the septum contracts, and then sometime later the free wall contracts. It's like Now that you can imagine that that is different from the normal activation of the ventricle, which is actually a squeezing, ringing motion, so which results from the apex right up to the base, like a ringing like that, all happening at the same time, is much more efficient. And it turns out that that actually is enough to drive heart failure. So left bundle branch block actually is associated with left ventricular dysfunction. And it's relevant to something. So that's one disadvantage of a pacemaker, so a pace rhythm. So what happens when you put a pacemaker in is the lead goes down to the right ventricle, and you're pacing the heart from the right ventricle, so it's a bit like left bundle branch block. It looks like on the ECG, and it has actually the same effect. So pacing in its own right can cause LV dysfunction. And so it turns out you can fix this, or at least maybe not entirely fix it, but you can certainly improve it by putting another pacing lead, by what we call biventricular pacing. So you put two leads in, one in the coronary sinus, around the coronary sinus, so you pace the left ventricle on the free wall, and one where you pace the ventricle from the right side, so you return it to more synchronous contraction like that. So that's called biventricular pacing, and is recommended in patients who have heart failure with systolic dysfunction and left bundle branch block. And that is shown to dramatically improve outcomes. So this is the other problem. I've already actually discussed this, so I don't need to discuss it again. But what's this rhythm? Just because it's so important, we may as well say it again. Atrial fibrillation. Yeah, so atrial fibrillation with a rapid ventricular rate is inefficient, can cause deterioration of left ventricular function over time with a rate-related cardiomyopathy. So that's why beta blocker, or making sure you get on top of rate control, is so important. Okay, and that can happen with atrial tachycardias as well, and we don't worry about it. So, so this is there's different sorts of heart failure. So there's low output. I guess low output heart failure is the main sort of. We normally think of heart failure as the failure of the heart to pump enough blood around. So that's low output heart failure, and then we divide into systolic and diastolic heart failure. So, from practical terms, actually, the systolic is the failure of the heart to empty enough blood, and the diastolic is a problem with the heart being able to fill up properly with blood. Now, in simple terms, probably it's better to think of heart failure in terms of reduced ejection fraction or preserved ejection fraction. So reduced ejection fraction is when the heart, when it pumps, it ejects a lesser volume out of the heart. And that's the one where we've got these evidence-based treatments that make a difference. Now, high output heart failure is very important to recognise because that means there's something meaning that there's driving a higher cardiac output. So if there's anything that flogs the heart over a long period of time will mean the heart muscle will fail. So I've said it with tachycardia, so if you make the heart rate fast all the time, but also if you have a high output, such as if you've got an arteriovenous fistula, and that actually is an issue with the dialysis patients, that there's a fistula there which is driving a higher output, but occasionally on thyrotoxicosis might be another example, or anemia might be a contributing factor to heart failure for that reason. And then right heart failure is, it happens when the right heart, obviously, for one reason or another, isn't doing its pumping job. So in those examples would be, I guess, cor pulmonale or pulmonary disease, or right ventricular infarction, where the right ventricle is infarcted and therefore doesn't contract very well. And then the problem is predominantly peripheral edema, so and a high filling pressure on the right side. But because it's not pumping the blood through the left side, you still get low cardiac output from that reason.